Okay, thank you, Harris. It's my great pleasure to be invited here, and cause here is 12 hours earlier than you guys, and I'm good evening here. Yeah, I haven't introduced myself. I'm also a perfusionist working for Shanghai Zhongshan Hospital, but now in Shanghai, the virus pandemic got be very good controlled. So in last 3 months, we fight for a long time for the virus, but so far we can kind of stage, we can get some conclusion to introduce some lessons we learned and some experience I want to share with you guys. So today I want to introduce the role of ECMO for the critical COVID-19 cases in Shanghai. Yes, my honor to on behalf of the Shanghai ECMO expert team, because we organize special task force to support very special infection disease hospital. This building I show in the front page is a temporary building. It looks very beautiful. It's just built it in 1 month, but it's the Shanghai's Plan B. It's empty now, but it's Shanghai's Plan B. Yeah, the first I've introduced the pandemic COVID-19 in Shanghai. I got the new data just today by China National Health Authority. Because in China, statistic, over 84,000 cases were going to be confirmed, but in Shanghai, you have to take the Shanghai have the 24 million population in this big city. But so far, because I experienced every case, confirmed the case in Shanghai. So in Shanghai today, we got the 639 cases got to be confirmed. But to guard this number, every people in Shanghai sacrifice a lot for their personal freedom, for everyone have to stay in the home, wear mask, keep the social distance, and all the business outside, and the small restaurant or big. And from the right figure, you can see, and from the January to the late of the March, most of the patients from inside of the China. Shanghai is one of the biggest city in China. And for the second wave, to our right side, start from the second week from the March, most the patient is from outside of Shanghai, because Shanghai is the biggest international flight port of China in last 2 months. So that's why the patient from outside China, the first from Europe, the second wave quite from States, and the third wave mostly is from Russia, increased very quickly. But so far, since it's controlled, all the international flights can be decreased or shut down. For the COVID Shanghai, we got a summary. The first case was confirmed on January. And until today, was 639 confirmed, and most of the patients discharged. Because all the patients admitted to a special designed hospital we call the Shanghai Public Health Center. It's a kind of infection special hospital. Generally, they just admit the patient who got the HIV, hepatitis, and tuberculosis. And the Shanghai local health authorities organize a medical staff from several general hospitals in Shanghai to form a support team. So that means almost 11 general hospitals are organized on a different team to support one hospital. So far, we got the 19 critical cases, seven unfortunately died, and 9 got be on ECMO. And for this 9, there were 4 already discharged. For all the 19 critical cases, 11 discharged home or in the rehabilitation service. The last critical case is still on mechanical ventilation when he is weaning off from the ECMO. Then for the ECMO cases, we've got 9, and I've got 1 ECPR have to IV mode, but unfortunately, this woman cannot be survived. And on VV mode in 8 cases. That's in 5 I just introduced. 1 ECPR, 1 is very fat, and 1 got a malignancy. They running ECMO for 37 days. 1 guy is very old, is in his 31 years old with some commodities, run ECMO on 47 days. The other woman is unfortunately facing very severe bleeding during the second weaning days in his ECMO day on 39. And we successfully withdraw 4 cases. separately on this ECMO 23rd days and 47, 40, and 50, 15. Three of it discharged home, looks very happy, and there's one I just introduced still on mechanical ventilation. So far, of course, there's no real magic pills for the COVID-19. In Shanghai, for the first 2 to 3 weeks, we try some pills or medicines for the HIV, but very quickly we think it's futile or no effect for the patient. For the hydroxychloroquine, we're still using that. We observed some trial, but the preliminary results showed it's kind of effect to prevent the mild case to the severe. But for the real critical cases, there are just no significant effects to protect the patient from getting more severe. So we issued a Shanghai ECMO support for COVID-19 guideline, which is published in a SCI recently. And this guideline already incorporated with the Shanghai export consensus for the virus. So in Shanghai, we use the same protocol, same guideline for all the patients. We organize, we call the Shanghai F7. It's like a rocket band, but for these 7 doctors, it's from six hospitals in different professional background. For this ECMO team, we have a supervisor, which is me, and 3 ECMO specialists. We keep the three of the 7 guys inside of the rest zone, 24 hours, 7 days. They included the one perfusionist, 1 intensivist, and 1 pulmonologist. The ECMO team's responsibility is to oversee ECMO management and participate in clinical evaluation and treatment, and have to communicate under the guidance with the Shanghai expert team. For these guys, we keep the 2 to 3 inside of the red zone and rotated every 4 weeks from these 7 guys. For the ECMO environment supplies, we have to say impossible is nothing, because in that special environment, we have met a lot of things. We handle it correctly and instantly, but it's very scary. Like the power supply got lost, the oxygen pressure is getting down very quickly, because all the patients standing a different building. Patients standing in one building. We call it the single negative pressure ICU room for each patient. We have to double backup for the power and the oxygen air supply for the possible slow reaction. Because generally, when all the PPE, when they dressed up, at least for 20 minutes. And because Shanghai local government organized a lot, we transport almost 12 ECMO devices and ECMO units to this one hospital. So it's good for us. We can use the same brand's ECMO instrument and disposable. Everything is the same. So we ordered ECMO units will be the current critical cases plus 2, and so far mostly we cost 6 patients in one time to running on ECMO. So mostly we prepared for 12 units, and disposables we prepare a lot, because the first January and February we are facing a lot of very difficult international logistics. For disposable supplies, no matter the cannulation, even the ACT cartridge by Medtronic, still we face a very strong shortage. We prepare a central ECMO card access in 15 meters. For the indication timing, we just keeping the standard AIDS treatment before ECMO, including the prompt position, the protective lung ventilation, optimal PEP, paralysis, and lung recruitment. But sometimes we have said the prompt position is not so helpful for certain patients. Almost I felt about 2/3 of the patients before the ECMO, the prompt position have no effects, even sometimes getting worse. So for the patients, ECMO should be actively considered when the PF ratio lower than 100, or pH lower than 7.25, or PCO2 more than 16 over 16 hours. And then sometimes for the certain patients, in our 9 cases, 3 cases, we have to immediately establish the ECMO support. For those patients, when the PF ratio lower than 50 over 1 hour or lower than 18 over 2 hours, or existence of uncompensated respiratory acidosis, which pH less than 7.2 for more than 1 hour, you can see the indication, the timing a little bit earlier than the earlier or traditional ARDS indication. But for us, I think for those kind of patients who suffer from very severe ARDS, timely set up the ECMO support is very crucial to save his life. For some patients, in the morning they are still in high flow, and during the afternoon have to intubate on ventilation, and even in the evening about 6 to 7 o'clock, they have to ECMO instantly. The infection control in ECMO for ECMO management are almost the same. If we did any invasive procedure, we must positive pressure mask. But for the regular ECMO routine, just an N95 mask with a facial fence, facial screen, that's enough. You can see the real things inside of negative pressure ICU units. Because this building is built in 2008 and the lift is not big enough, they cannot hold all the instruments, including ECMO devices. So the EIT is very helpful to evaluate the patients. And for our cases, we got 3 EIT devices for all the patients. So that's why we ECMO team have to evaluate the patient by EIT every day. ECMO experiment almost look the same, but on such kind, you protect yourself very carefully. You have a three-layer growth. Your fingers feel totally different. You can feel nothing, especially for the vascular access. For the ECPR, we don't have any more choices to have on VA ECMO. But for the rest of the patient, VA ECMO, we must correct the hypoxia instantly. And we use because we don't have the double lumen cannula in China. So the internal jugular vein and the femoral vein is for all the patients. But for this kind of a patient, there's most of the patients in their first and the second weeks, they suffer the same of the very significant gastrointestinal disturbance. So that in their abdominal pressure is very high. If they cannot release it instantly, they have some bad effects on the ECMO flow. So that's why the position of the drainage cannula, we adjust it about 1 centimeters beyond the IVC contraction inside of the right atrium. So when we put this position, most of the patients can be sustained very stable blood flow during the whole process of ECMO. For the rest of ECMO management, almost the same. We have keep the DO2 and the VO2 in balance. We keep the enough ECMO flow, hemoglobin, and the patient's cardiac outputs in the balance. We keep the hemoglobin over 11, and the balance between supply of oxygen and consumer over the ratio more than 3. For the gastrointestinal dysfunction I just mentioned, we have used a lot of things to make the abdominal pressure is getting down, because especially in the first and the second week, it's so obvious. And sometimes it happens. I heard some report from other centers outside of Shanghai. The ECMO blood flow can be getting down very quickly, even until 0. The patient can be passed away very quickly if you cannot handle it correctly. The anticoagulation almost the same as for the other VV ECMO supports, but we're facing a very significant heparin resistance and low antithrombin. So FFP transfusion, we have to do it very often. There's one patient we were suspected of HIT, but unfortunately we don't have such kind of certain antibody identification. So, but we changed the heparin to the atratroban for the second day. But for the ECMO circuit replacements, when the significant thrombosis in oxygenator or the dimer over more than 10 or 5 lower than 1.5, when the TEG confirms the whole ECMO circuit have to replacement, just keep the cannula inside. Some of the patients significant bleeding or need invasive procedures. The heparin may be reduced or suspended maximum to over 1 day. The hypercoagulability and the hyperfibrinolysis is very popular. You can see the light blue line, which is the D-dimer. D-dimer for the first 1 to 2 weeks looks a bit increase very close, very slowly, but almost in this 12 to 15 days, have to get to the peak. We have to change the whole ECMO circuits. But for the second round, you can see when we change the new circuits, but until the 7 to 10 days, it will come back again. And we have to another 10 to 12 days and change the second one. It's round. So the most patients, we can see from this table, for the 7 cases we listed in this figure, change to the ECMO circuits 3 to 4 times is very popular for those patients. So that's why the coagulation related events, whether it's the mild bleeding or the deep vein thrombosis, is very popular for this patient. We have to be very careful to monitor it and treat it instantly. And for the daily point of care ultrasound during ECMO, because our ECMO team take the role to take the monitoring by echo. For the lungs, for the heart, for the abdominal and the vascular, for the VTEs, we have do it as a daily routine. One point we respectively to check all the patients who got survived. Well, the most important, we keep patients for the ventilation strategy in an extra protective ventilation strategy. I think all guys were very familiar for that. But some of the intensivists advocate of the weak ECMO for those kind of COVID-19 patients. But in Shanghai, we find a weak ECMO is very hard to make it, because if the patient mild is getting weak, their spontaneous breath is very strong. So the driving pressure for the patient is very big, much more than 20. So that's why we've just felt a weak ECMO, especially the patient for the first 2 to 3 weeks, almost it's hard to make it. So that's why a weak ECMO is not recommended in Shanghai. For the lung mechanical evaluation of the CT scan, the blood gas, the chest X-ray, but I think the most helpful is the EIT. The weaning procedure we have got more conservative than the regular ARDS, especially we issued 6 standards for when we decided to discontinue from ECMO support, which is the hemodynamic stability, improvements on chest radiography, especially the EIT and the chest CT. PF ratio must more than 150, PCO2 lower than 50, and the rates less than 20. No fever, the Murray score 2 to 3, and the hematocrit over 35%. And if the patient match this criteria, we have to still keep the patient on ECMO, but no sweeping gas in 1 to 2 days to really 100% to confirm the patient is stable. We have to provide some preliminary results. The baseline is the same, but you can see the most patients are male. Their age, mostly they are over 16. There were 2 cases over 70 and 1 case over 18. We have to say sometimes it's a hard choice to decide the patient need ECMO or not, but we have to concern a lot. But in Shanghai this time, all the government invests a lot. All the medical resources can be guaranteed. So that's why for those kind of patients, even his age is over 80, we still want to try to save his life. But unfortunately, after 47 days has no effect, and finally we give up. And for the commodities, hypertension is popular, diabetes is popular, and some patients got the cardiovascular disease. One got malignancy, and one got cerebral vascular disease. COPD is popular, and 2 cases got chronic kidney disease. The Murray score before ECMO is around 4. Generally, the PF ratio is very low, lower than 80, and the lactate before looks not bad. And this time it's very funny because even the PF ratio is very low, but the lactate can be looked normal for a very long time. The days before the ECMO, the mechanical ventilation, generally the survival case is less than 7 days, but for the rest who passed away is also over 7 days. So the time of ECMO days looks much longer than the general ARDS. So we can see there are three patients discharged back to home, and one still in the mechanical ventilation. For the survival, the one is 47 days, and another one, the second one is 40 days. For the rest, it's very long. So I have to conclude some things about the ECMO expert team for the pandemic. Because in Shanghai, ECMO, this is a technique already in clinic for over 20 years. Before that, a different specialty, no matter perfusionist, the intensive care, the emergency, the pulmonary diseases, have a lot of academic communication and some mutual support. The A hospitals team want to support B, or B supposed to C. And we've got a lot of multidiscipline MDT teams inside of the hospital and between the hospitals. And that's a good critical quality control organized by Shanghai local health authority in 2 years ago. In that quality control investigation, we found that there were 15 general hospital is capable for the ECMO, because all the centers, their annual ECMO cases is over 15. And we got in Shanghai in 2018, there's over 36 ECMO instruments in Shanghai. So this time, over 1/3 of the instruments have to transport to one center to treat those kind of virus patients. And we know each other. We got who will be the most experienced one, and we share the same protocol. And for the ECMO indication, as I mentioned, the timing, we must to say always too late. But for the patient, if all the medical resources are available in Shanghai, so that's why for the patient, anytime, if we do everything, follow the instruction for the ARDS NAT, but if the patient cannot reverse from the very severe hypoxia, the ECMO will be indicated, and we set up ECMO in at least in 1 hour. But some lessons we have to learn. We have to avoid the patient into the very severe and the critical stage is the highest demand for treat the patient. So now in Shanghai, we don't have the new critical cases because we from our protocol, we use especially the immune support, the nutrition support for the mild cases to prevent them to get into the severe stage. And we must ensure the effective and timely and same ECMO support for those kind of patients. And these two patients just discharged last Wednesday. We were happy for that. I think these two patients, this picture, they shake hands in the outside of the ICU. They looks very, very good. It's best reward for us. Some nurses dropping their tears. And I have to say, because the pandemic in States is very severe, much severe than what happened in China. So that's why I strongly suggest that just the social distance is totally not enough. All the medical staff have to protect themselves very carefully. Glove, mask, for everything. In China, it's in Shanghai, the government order us without good protection, just away from the patient, just away from any risk. We don't need a hero. We just need real medical staff for the future. So thank you so much. Thanks for attention. And thank you again for inviting me here. Thank you.